So what we are doing with those guys is we're following them closely. They get rebiopsied once a year, unfortunately, because you have to do that. And I have had a number of men, about 1/3 of men will go on to progress and they will actually require treatment. So you could argue that you are sparing 2/3 of men in an active surveillance profile or protocol. You're sparing 2/3 of men the morbidity of radiation or surgery. So I know that was a long-winded answer, but I thought that was a great question that one of the few non-physicians in the room asked. Thank you, Gary. Mark?
I'd just like to kind of ask a basic question as a non-internist, non-family physician. What is the recommended approach to patients now? Let's say you're 40 years old versus 50 or 60. How often do you see your primary care doctor? How much time are they supposed to spend with you? Taking, how much paperwork you're supposed to fill out, history, physical. Do you get into a gown and take everything off except your underpants? Seriously, when I was in medical school 1,000 years ago, we were taught to spend a huge amount of time with patients. I know there are money-related issues making that less likely now, but where do we stand with, actually, I see a lot of people as an allergist who come in who've never been immunized, people 50 years of age or 60 or 70 are missing immunizations, and for us that's a big issue. So what do you...
Okay, well, this is more of an anecdotal answer, I guess. The reading through the guidelines, there's not much in them to answer your question. The interval, or the who do we do a yearly exam, but the one thing that's referenced is probably recommended after 40 to start doing a yearly exam, but not much else to answer your questions. There is some literature that's looked at the value of physical exam, just wrote yearly physical exam and the benefits of going through emotions like
starting
you're taught and head to toe in medical school, but really more of a focused exam is beneficial. But as far as the prognostic value of head to toe kind of thing, even though it's a balance between patients, I think, feel comforted by that. Is that science? Is that no, but it's really it's kind of an art, like they say, that we do, and trying to find a balance between that and because in a cost-conscious world, physical exam is cheap. It's nearly free. You could argue.
It takes time.
Right. So it's arguable if it's free, but it's essentially free. However, there's similar issues to the PSA, even with the physical exam. You can find something that kind of makes you start chasing some abnormal finding and tests and such that, for something that's not really there.
Israel, and then we'll do Jane.
Question, Michael, regarding the current status of screening for vitamin D deficiency and vitamin D replacement, and I know that the pendulum has been swinging back and forth. What is the current status?
Yeah, I did look at that specifically in preparing for this, and certainly from the Preventive Services Task Force, there's no comment one way or another. I would say that routines. There's a big difference between routine screening and more diagnostic screening, and because the symptoms.
In the absence of osteoporosis, normal calcium, you don't have pathology, just to screen to see if somebody has deficiency.
There's very little recommendations for that, but I would add that the symptoms of vitamin D deficiency are extremely varied and protean, and it can affect almost any organ system. And I think that I have a very low threshold, and I think that we're thinking of a very low threshold for not routine screening, but for looking at vitamin D levels.
Howard.
Yeah,
Sorry.
there's two questions. One is shingles vaccine, how long is it good for, number one? And number two, on the prostate, the PSA, didn't it used to be Medicare wouldn't pay for quote routine over age 70? What is the...
PSA?
PSA's covered.
Okay. The shingles vaccine, as of now, is a one-time vaccine. Recommendations are for everyone over age 60 presently. Within the last year, there's a consideration for 50 and above. Okay, that's the same kind of similar thing with insurances are generally not covering between 50 and 60, so it's a little more difficult sell for people because it's an expensive vaccine.
I don't think Medicare pays for the vaccine itself. I think my wife and I had to pay out of pocket.
Actually, generally Medicare has pretty good coverage if you go through the right hoops and get it done in the appropriate place. It's actually the private insurances that it's more of an issue.
One more question from Gene, and then I'll get started because I have a little
comment. And with PSA and with what Gary said, there's this elephant in the exam room. If the patient says, for example, I want a PSA, and the doctor says, well, you really don't need one, and here are the guidelines, and here's why you don't need one. And if a year after that he ends up having prostate cancer, I think from the standpoint of litigation, an answer that, well, I didn't do it because the guidelines said I don't have to do it. I don't think that'll hold any water with that. And I just want, if you have an opinion on the vaccine for adults for whooping cough, which is now available.
Yes, so yeah, certainly the PSA issue. I haven't really changed my style of practice as far as the PSA goes. Maybe that's Frank whispering in my ear about that, but no. So there's what you do and what you feel comfortable with practicing, and so you always have to. So I'll say these are just guidelines. I'm presenting them because they are formalized, but it's you can do what you feel you need to do clinically. Whooping cough. Yeah. So as far as the recommendations for, and generally the vaccines are combined with tetanus, diphtheria, and pertussis. Okay. Last few years, there was a push for the 18 to 64 age group to use the combination rather than just the tetanus booster. And just recently, various groups have started saying that even in the 65 and older, where that has been a recent change, to also give the combined tetanus, diphtheria, and pertussis booster, Adasol or whatever brand you might want to give. And as far as the efficacy, is that what wasn't sure exactly what you were asking.
Yeah.
I don't have a good answer for that. I'm not sure.
All right, so I think I covered PSA. 50 years of age, digital exam, and a PSA level 45 if African American or family risk. And then when I stop checking for PSA, and this is a recommendation I do follow, if you think that the patient has less than 10 years life expectancy, you probably shouldn't be screening them for PSA. What I will do is I'll still do a digital examination, because what I'd hate to miss is an 85-year-old guy comes in the office and he says, oh, I really want to be screened for my prostate cancer, and I'll do a digital examination on him. If that rectal exam is grossly abnormal, I will talk to them about checking a PSA level. But I will warn them about, that's a slippery slope, and if we go down that ledge, where are we going from there? Do we need a biopsy? I would never operate or probably even radiate someone that age, but they could very well have both quantity and quality of life extended very simply by getting a testosterone blocking shot, an LH-RH agonist, something like Trelstar, Lupron, Zoladex, and you get it twice a year, a 6-month depot, and it can prevent bone metastasis and dramatically improve quality of life. So there are definitely some benefits to that.